deliver it amidst the challenges of the new normal. And in our case, we have two immediate goals. That is to officially close the last school year's term. I believe that you are aware that most of our Philippine dental colleges have yet to complete our second semester when the contagion or the pandemic hit the Philippines sometime in March, early March. So we need to officially close that term, and we need to make sure that the students will be given a chance to complete their subjects and will be given the right assessment based on the restrictions of the then prevailing community quarantine. And also, we will have to begin the planning and preparations for the next school year. Let me just on the onset, uh, share to you what we did in as we closed the last year's term. We all agreed that we will not give a failing mark on those students who were not able to complete their academic and clinical requirements. Most of them were given incomplete grades, giving them chance to complete their courses and be given the rightful grades. But the manner of assessment or completion will be dependent on the institution's compliance with the restrictions as implemented by the interagency task force, which are mandated to implement the quarantine rules in the Philippines or in the country. So what we have now is a summer. Summer starts now at by June, and it will end in July. And the first semester we will all begin at August. So the completion uh, will be a period will be up to the second semester, depending on the nature of the subject. If it will be a prerequisite to a higher offering, then the student should volunteer to subject himself to assessment and therefore given a chance to complete the last year's terms subjects. We also have to prepare for the next school year. Now we are all forced, all the schools are forced to follow the governmental regulation as implemented by the Commission on Higher Education based on the following allowable engagements. For this summer, which will be covering from June to July, the government is only allowing purely online classes. Then on August, the CHED, or the Commission on Higher Education, will now allow a flexible classes. That means that there will be online or mixed or combination of online classes and a face-to-face engagement. And on September 2020, the government will, based on, of course, the assessment of the interagency task force, might allow face-to-face student engagement. Now, when we say face-to-face student engagement, it is more of the teacher and the students in their classes. So we need to really clamor from the Commission on Higher Education to understand us more, that we need to be given the go signal to have a face-to-face engagement with our patients because as you might be all aware of, dentistry has a direct patient care component. Now, having this restriction laid down, the PADC, the various deans, shared their time and talent to come up with the work continuity plan based on the recommendation of the National Institute for Occupational Safety and Health. While we are more adept on how to deliver the dental education program, we have to see the new normal scenario on the point of view of a safety officer. So we decided to implement or to plan and implement the work continuity plan having these 5 pillars as our guides. So elimination, substitution, engineering controls, administrative controls, and personal protective equipment. Under elimination, which is designed to remove the health hazard, well, I think we are one in praying real hard that a cure and vaccine will be soon developed. And that will confidently convince us that there is a chance to really eliminate or remove the health hazard. Having said that one, just to make sure that we have somewhat addressed this kind of health control, we indulge into a lot of health screening to isolate the well from those who are affected. So now there's a lot of thermoscanning, health assessment forms that should be filled up before you can enter the school premises. And there's a lot of protocols on reporting of individuals who might be suffering from the established symptoms of the contagion. On the substitution rung, which actually is designed to replace the hazard, we all agreed that if we are not be allowed to have a face-to-face engagement, we will substitute direct patient care with simulated bench exercises, just like what the other schools have presented. I think that's a universal concern amongst dental education in the region. And we are also following the same recommendation. On engineering control, which is actually put up to isolate people from the hazard, in a not so developed country, we have to have a lot of retrofitting of our dental wellness center or infirmary, particularly in terms of air filtration and evacuation system. And this will entail a lot of capital infusion on the university administration. And it also entails installation of barriers to assure compliance with the principles of social distancing and traffic flow. And to complement these engineering controls, we need to review and perhaps enhance our waste management system and facilities, because we will be expecting a lot of or an increase on wastage, particularly on used PPEs. This rung, or the administrative controls, is something that we can play around with to address the challenges of the new contagion, because these controls change the way people work in order to ascertain that, to assure that every stakeholder will be safe and healthy as they perform their individual task or duty. The main key right here is to reduce the exposure of individuals. So therefore, there is a general screening on wellness and health of everyone. And I think some of the presentation have already underscored that they are really considering not to send their students anymore to community or to hospitals for immersion or their what we call medical duty. For one, a lot of hospitals are limiting their staff. And as you might be aware of, OJT's students might add to the congestion of the already congested facilities. And sending our students in social orientation and community involvement projects might be too risky because we have not, or it will take a lot on the part of the university in assuring that the community, the adopted community, will not be a health risk to our students and to our faculty members. So community dentistry and hospital dentistry will be recalibrated, and perhaps it will be the program of instruction will now be shifted to online instruction and video demonstration to appreciate the already established learning objectives of those two subjects. Also, as you might be aware of, there is to reduce exposure, there's a general migration from physical to virtual classes. And in a not so rich country, this is really a concern to us. Some of the presentation presented challenges on the pedagogical acumen of teachers in indulging into an online classes, and learners' fiber in coping up with the delivery of instructions through the various online platforms. But for us in the Philippines, what concerns us the most is the quality of connectivity. It is not only the quality of the connectivity, but also the how you can sustain your connection as the online classes is going on. There's also this synchronous and asynchronous online classes to make sure that there will be less people that can be housed in the college, because we will be planning to downsize the customary classes of 50. Easily it will be reduced to 20, so as to, or 25, depending on the dimension of the classes, just to follow the social distancing principles. Some, or I think we will be compelled to do cluster or block subjects, because as I've told you, there will be a progressive, let's say, lax or relaxing of the restrictions from online to flexible to face-to-face classes. So what we are planning is to, in a subject, we have both didactic lectures and laboratory exercises. We will cluster the theoretical input on the earlier part of the offering, so that at the time when we are about to go to the bench exercises, or experiments, it might jibe with the schedule whereby whereby the government will now be allowing a face-to-face engagement. As I've told you earlier, the reduction in or elimination of direct patient care is part of the administrative control. It is to reduce the exposure of our students and our faculty. And simulation best exercises is what we term as equivalence. I think those who have already been into direct patient care would agree that simulation exercises, while it may be doable, it might not be lacking with fidelity as to the opportunity for the for the for the instructor to guide the clinician as to what to do, and the clinician equally demonstrating back what he has assimilated. So this is something that is actually we would want to be enhanced, and perhaps those people here in the symposium can share their experiences. And part of the admin control will be there will be no more walk-in admissions to direct patient care. If ever they will gonna open our clinics, there will be remote or online or phone reservation. This is to minimize the time, the amount of the number of people in the clinic itself or in the waiting areas, and to make it more efficient in admitting and managing each cases. And as you might be aware of, one of the medium for transmission of these viruses is through the aerosol. So there will be liberal use of aerosol barriers, and a lot of creativity were poured in into the development or design and development of such barriers. Ingress and egress sanitation and inspection protocol would be now more strict, and it would involve not only the student but also the faculty, making sure that that such protocol is implemented on the dot before the chair is used and after its use. And of course, the storage of the used instruments or the supplies should also be monitored. Again, this is this kind of changes in the didactic lectures, with laboratory and clinical dentistry would follow the graduated progressive scheduling of relaxing of restrictions as mandated by the government. Here's an example of a aerosol barrier, as you can see. No? It's a simple guard to prevent if ever, the aerosol from splattering to the operator. And we are scheduling all AGP or aerosol generating procedures on the latter part of the day, so that it will not affect those clinicians or procedures being done by the clinicians, no, in the earlier part of the session. So you see now we have put up, I've just mentioned some of the ways where we can use the 5 rank of controls to assure that there are safety controls in place to ward off or to contain the health risk being posted by the new contagion. But there are still challenges lurking around us as we implement this dental program. One of which is psychological in nature. After knowing that the dentistry is one of the top two, if not the top profession, which can generate aerosols that can pose health risks to, to the public or to the patient or to the public, a lot of parents are really apprehensive, concerned of their sending back their their children to dentistry. So this is coupled or complemented by the challenge mental health of the various clinicians. There's a lot of apprehension, anxiety that they may caught such virus within that kind of what we call high risk facilities with as they do their high risk procedure. So mental health is an important aspect and perception that the university administration, the faculty are prepared to guide them and to protect them is an utmost importance for them as they enjoy more again in their journey towards a relevant dental education. Then there are the rest, pedagogical, technical, economic, and environmental. I'm really happy that my good friend Kelvin, Professor Kelvin, talk about assessment. But because there's a growing hesitation amongst the dental professors in the Philippines with regards to online classes. Not that they don't know how to do it, but because they appreciate more that dentistry is a professional training program, and having said that one, we are training our students to be professional. And one of the tenets of being a professional is having that empathy to your patient. And that can only be cultivated if the learning process uh, give equal premium on affective domain. And still, a lot of traditional dental faculty members believe that professionalism or that high work ethics may only be truly demonstrated and observed at chairside. So they are still hesitant as to how, in spite of the so many video presentation, can assure that the students have assimilated the right attitude to become a disciple of the dental profession. Maybe we can have a long and we say intensive consultation with my good friend Dr. Kelvin on that matter. Dentistry is a transformation from a general public person to a person for the other public or for other people. Dentistry is a profession for other people. It's a transformation of people to possess not only cognitive skills but also the affective soft skills of a person treating a person. We always subscribe to the philosophy improving man as man. Of course, we are all hopeful that there will be manners, modalities of treatment that can modalities of teaching that can enhance such kind of so you say affective domain. And actually, it's not more of the delivery. I think dental educators have already possessed that drive, that passion to impart professionalism amongst their students. What remains to be, so we say, for them to be convinced is that how would we know if the patient, if the students have really acquired what we want them to become? These are just the usual domains of the affective and the cognitive. And I think this should be a heads up that when we develop online learning curriculum or courses, we need to incorporate them. For instance, in the affective factors as like self-identity, self-value, self-directedness, and self-accountability are tenets for a self-regulated profession like ours, dentistry. And this is one of the this actually is displayed in my office. You can be the most intelligent, the most skillful, but if you don't have the heart for your patient, those two might be lacking or wanting. Or we always subscribe to the dictum, the heart of education is the education of the heart. Once the heart understands its role, the two would follow. Another challenges will be the end product assessment versus process-based assessment. While we laboriously ambition that our clinicians will have that certain high level of independence of decision, of self-regulated, so you say, management of their cases. That is the ultimate goal. And in an end product assessment, we might lose the chance or opportunity to monitor the progressive development of the skills of the clinician. So people in the government would want an end product assessment so as to reduce exposure of both the student and the faculty members. But a lot of the faculty members says, how can we see the development if we will only be seeing the end product? There's a lot of learning lessons and opportunities if we will do it step-by-step procedure. This is where the master would impart his own, so we say, prowess or expertise to his students. This is also for the satisfaction, better satisfaction and safety of the patient, if ever. I've told you, quality of connectivity. We envy Singapore, Dr. Kelvin. You have one of the better connectivity. If yours is 12, ours is 2. So I think you now understand that while we will want to indulge into such kind of classes, not all may have the quality, good connectivity to sustain their stay with the online classes. And if you are connected, how good is your connection? So it might lead to just a disrupted uh, engagement. And I think this is actually appreciated by my good friend Dr. Kelvin, because he himself would set up a backup for all those Zoom meetings. And I think I'll learn a lot from this one. No? Because even in a country where connectivity is at best, these things would happen. So we are complementing uh, synchronous learning with learning packets that will be can be downloaded by the students, and can be appreciated even though they are not online. Everything would lead to a surge in the cost of study. The most they can have without in the Philippines, the recommended uh, online period per day or per session is only 3 hours. And the 3 hours there will be really a big increase in the daily expense of the patient. No, I mean say students. And of course, if it's a simulation exercises, you will have a lot of typodons simulation equipment that you will be needing. Of course, not to mention, as I think I've said that before, the management of waste, particularly the increase in the volume of plastics and disposable PPEs. Yeah, this is part of the waste management. You know? Potential changes to practice, such as for the collection and handling of waste management, waste materials from the clinic to the waste recovery facilities. And knowing the character of the virus, there might be some withholding times so that it will not be harmful to the handlers or collectors of waste. It will be a new journey for all of us. But many of us agree, I think high 90% of collaboration is the key. Sharing information, sharing our best practices can make us all weather the threat and challenges of this contagion. We will all be here together in the journey towards the new normal. We will all navigate, and we will navigate alone. We will seek the help of other dental educators amongst us. And to honor Alan Shu and his team, I have these small parting words. In the era of pandemic, Taiwan, we will walk towards an ardent, independent, we'll all navigate. Thank you very much for your time. That will be all.
Okay. Thank you, Professor Di Naturo, for sharing us so much precious information. And before we end up this session, and I would like to thank all of the participants and the speakers. And because of the limit of time, I would like to ask the President, Professor Wei-Ren Zhang, to deliver close remarks.
Okay, thank you, Professor Alan Shu. And also, I would like to thank all of the speakers, all of the moderators, and all of the participants to join this online symposium. And we had a very fulfill speech today. And we also got a very new a new method and a new concept for the dentistry. So thank you for your participation. And I wish we can be safe in the future soon. Thank you so much. Thank you for your participation.
Thank you. Thank you, Renato. Thank you, Sandro. Thank you.
Bye bye.
Thank you, Yawaka. Thank you. Bye bye. 红光，谢谢，拜拜。
Bye. Okay.
Thank you.
Bye.
Thank you. 好，可以同样的
Bye for this time. Thank you.
Thanks so much.